Today we're going to address the questions: what is Virchow's node and why is it important? Virchow's node is a specific lymph node on the left side of the neck. It's on the inframedial aspect of left level 4. This is where the internal jugular chain of lymph nodes meets the transverse cervical chain, very near the terminus of the thoracic duct. Now, it doesn't have to be in an exact location. It's in this vague region that we refer to as Virchow's node. Why Virchow's node is important is that it may receive metastases from the abdomen or pelvis that have bypassed the chest. Normally, we think that a node in this location must be receiving metastatic disease from nodes that are more superior, flowing down, or nodes in the upper mediastinum flowing up. But it is weird to have a nodal metastasis that has skipped over all of the nearby nodes and appeared in the neck, even though the primary and all other metastatic disease is in the abdomen or pelvis. Presumably, this is explained by the thoracic duct and that these lymphatic metastases have traveled up through the thoracic duct into the neck. Now, note that it is only on the left side of the neck. It turns out that 5% of people also have a right-sided thoracic duct in addition to their left-sided thoracic duct, but I personally have never seen this phenomenon occur on the right. Maybe it's just a rare enough event that I haven't seen it. Virchow originally described this node in relation to gastric cancer, but any abdominal or pelvic cancer can theoretically do it. The purpose of this lecture is not to just list every form of subdiaphragmatic cancer, it's to emphasize the importance of Virchow's node and to recognize its special relationship to abdominal malignancies. Every case that I'm about to show you had no evidence of disease in the chest and no other evidence of disease in the neck. Everything else was distant from this node. Let's start with the classic example of gastric cancer. This is what was originally described by Virchow, and this is the node from the abdomen representing gastric cancer presenting in the neck. Moving down the digestive tract, duodenal adenocarcinoma, these two nodes. It is often true that a Virchow's node is initially involved and then the other nodes in the transverse cervical chain become involved afterwards. So don't be surprised if there are several nodes, one of which is Virchow's node. Moving down the digestive system, how about the jejunum? This is a jejunal carcinoid. In the ileum, we have a neuroendocrine carcinoma that has metastasized to Virchow's node. Colon cancer. Here's the node right in front of the anterior scalene muscle. This one's colon cancer. Nothing in the chest, just jumped up to the neck. Moving on, here is a rectal carcinoma. And finally, an anal squamous cell carcinoma. This is the node right here on this PET-CT image. What about the liver? Hepatocellular carcinoma, very aggressive metastatic lesion encasing the common carotid artery here. Hepatocellular carcinoma. The biliary system, this is a biliary ductal carcinoma. And here's a cholangiocarcinoma, all of these Mets merged together. Pheochromocytoma, only 10% of them malignant, but when it is malignant, it can produce metastatic disease that jumps up into the neck. And this is often the presenting symptom is a neck mass. How about the renal collecting system? Well, this is a renal cell carcinoma responsible for these two nodes. Here's a urothelial carcinoma from somewhere along the ureter. And this is a transitional cell carcinoma of the bladder. Moving to gynecologic malignancies, this node came from vulvar carcinoma. This is cervical carcinoma, a very aggressive appearance. Here's an endometrial carcinoma. And this one is a uterine sarcoma. This is an ovarian carcinoma. This is a surprisingly common primary tumor to present as a mass in Virchow's node. I don't want to leave out the male reproductive system. This is a seminoma jumping up into the neck. Here's an adenocarcinoma of unknown primary. There was extensive retroperitoneal metastatic disease, and then this one big node in the neck that was the patient's presenting symptom. Very aggressive. We never found out exactly where this came from before the patient died. Now, there are some primary tumors that are not unique to the abdomen, so perhaps it's less surprising that they might appear in Virchow's node. But these are still examples of disease where all of the other disease was in the abdomen and pelvis, and the only manifestation above the level of the diaphragm was Virchow's node. Here's an example of Hodgkin's lymphoma. Melanoma, perhaps not shocking that melanoma can simply travel wherever it wants to. Here's an example of leukemia, and the solid manifestations of this leukemia, actually a CLL, were all here in this node and in the abdomen. Castleman's disease, again, not surprising that it might appear in an isolated lymph node in the neck, but here it is in Virchow's node, along with some abdominal disease. So in summary, when Virchow's node is enlarged and there is no primary in the neck or chest, suggest imaging of the abdomen and pelvis. Perhaps the disease has jumped up from lymphatics in the abdomen and pelvis to present as neck disease. Remember also that Virchow's node is really not a specific node, but rather a nodal region, and anything in the medial aspect of level 4 should be considered adequately close to Virchow's node to count for this analysis.